Welcome to this webinar. My name is Marta González. I'm Product Manager at Cytocnos, and I want to thank you for your interest and for sharing with us the next minutes. It is my pleasure to introduce to you Daniela Damasceno, our invited speaker, who will present to you how to apply blood monocyte subsets evaluation in clinical practice. Daniela has a degree in biomedical science, a master's degree in molecular biomedicine, and a master's degree in cancer biology. She is also a medicine student since 2017. Currently, she is in her last year of doctoral thesis, which consists on the monitoring of patients with multiple myeloma through the analysis of circulating tissue macrophages by flow cytometry. She is also a researcher for the Periscope and TMASCAN projects. Welcome, Daniela, and thank you very much for being here today.
Hello, thank you for your nice introduction, and thank you for the invitation to be here today presenting this webinar on blood monocyte subsets in clinical practice. Thank you also for the people that is attending this webinar. Today we are going to see some applications of blood monocyte subsets in blood for clinical practice for different conditions that were already studied in the literature. Then we want also to show you in the end a demo with a real case of a healthy donor, and then we will be able to analyze for ourselves the populations and to learn how to do it in an easy way. To begin with, it's important we understand the difference of the components of monocyte macrophage system. The system includes cells from peripheral blood, monocytes, but also macrophages resident in tissues or macrophages that are circulating between tissues and peripheral blood. So, to understand these differences, I brought here today this slide in order to show you the tissue-resident macrophages. Tissue-resident macrophages are very important in the maintenance of homeostasis, and also they accomplish functions in metabolism, in repair, and they are very plastic cells that can be transplanted from one organ to other, and they can adapt the new profile from the organ of destiny. Here we can see several examples of tissue-resident macrophages. We see microglia present in brain. We see also alveolar macrophages responsible for the elimination of dust, allergens, and microorganisms. We also appreciate Kupffer cells from liver, important in the clearance of pathogens and toxins. Bone marrow macrophages, also osteoclasts, present in balance with osteoblasts in bone resorption and reabsorption. And you can see much more examples. We have also intestinal macrophages. We have also skin macrophages that are important in phagocytosis and antigen presentation. And the main message from this slide is that all of these macrophages are specific from the tissue they reside, and they are important in the clearance of the debris and the dead cells in their tissue. On the other hand, we have blood monocytes and tissue macrophages recirculating in blood. The monocytes have their origin in bone marrow. So they differentiate from the precursor, monoblasts. Monoblasts differentiate into promonocytes, which then give rise to mature monocytes. Once they reach this stage of differentiation, mature monocytes migrate from bone marrow to peripheral blood. And here they will be together with the other leukocytes present in peripheral blood. In 2011, Professor Van Dongen and Professor Rafal, they developed a theory, patented in the same year, that shows that monocytes coming from bone marrow enter the circulation, and here they can migrate to tissues and then recirculate via lymph system to blood again. But when does this happen? So this happens under inflammatory conditions or under tumor conditions. And these cells, when the homeostasis is disrupted, they are called to the tissues, and together with the tissue resident macrophages we have just seen in the other slide, they will clean the debris and the tumoral proteins. They will accomplish phagocytosis of the tissue debris, and then they recirculate via the lymph system to peripheral blood. According to the National Committee of the Immunological Society, a new nomenclature was given to these cells in order to make consistent all the studies in literature. So before this nomenclature, we had a lot of studies, but each one was giving its own nomenclature to these cells, and now it's easier to understand and to know which cells are we talking about, because they are all the time called the same way. So according to this nomenclature, we have classical monocytes, which are strong, they have strong expression of CD14, which is the LPS receptor, and they are negative for CD16, which is the low affinity IgG receptor. Then intermediate monocytes, which would be already cells that migrate from tissue to peripheral blood, and so they will have these fragments, these peptides of the tumor inside the cytoplasm, and these cells are characterized by their strong expression of 14, but differently from classical monocytes, they do express CD16. And finally, non-classical monocytes, also cells that come from the tissue after accomplishing phagocytosis. They will also have tumoral peptide in the cytoplasm, and phenotypically they are CD14 deemed negative. They already lose this marker, but they maintain strong the CD16. So these are our cells, and these cells are differently distributed in peripheral blood. This is a healthy donor example. The percentages we see here are in classical monocytes. They account from 80 to 90% of total monocytes in blood, and intermediate monocytes together with non-classical monocytes can go from 5 to 10% of total monocytes in blood. These cells, as we have seen already, are separated, classified according to the CD14 and CD16 expression, but the first step in the analysis, it's the identification of all the compartment together and separating it from the other leukocytes. And this is possible thanks to the identification markers that can be also included in our panel, which will be HLA-DR, as we know, presenting cells, antigen-presenting cells, all express HLA-DR, together with CD300E to make our identification 100% correct without contamination of other leukocytes. So this would be a very nice way to separate our cells. And today the goal of this webinar is for me to show you the importance of monitoring monocytes or monocyte subsets in the detection of homeostasis imbalance in different conditions that were already reported in literature. So what I have done was get these examples, these studies, and show you in which way the authors used the monitoring of monocytes for each condition under study. For this purpose, we will show here some examples. We know that I want to highlight the importance of monitoring blood monocytes, both in clinical studies or in other applications. In the hemato-oncology field, it's already very common to study these cells. We have the example of AML or MDS, CMML that we are seeing later. Also in the cardiology field, in coronary artery disease, and also chronic kidney disease as also results on this field. And here I brought you the Kaplan-Meier analysis on chronic kidney disease patients, And the authors saw that patients with high levels of classical monocytes had a poor prognosis and a worse outcome compared with patients that had lower levels of classical monocytes. This is just a small example, but we are seeing now in detail CMML and coronary artery disease studies. I will also mention other applications like tissue damage in total hip replacement, and also highlight the importance of having databases with reference values of blood monocyte subsets in order to make good comparisons and have nice results when we are studying our patients. And these reference values will be showed by age group, because the monocytes have also kinetics according to age group. So to begin with, we are talking about chronic myelomonocytic leukemia, CMML. This condition is an hematological disorder classified in 2016 by the World Health Organization as a myeloid neoplasm, and is defined as a clonal hematopoietic stem cell disorder. It's characterized by monocytosis in peripheral blood, and this monocytosis has to be sustained for 3 or more months, together with bone marrow dysplastic features. In this study, the authors were thinking, if we have several subsets of monocytes, which one are increased in CMML? Would it be classical monocytes, intermediate monocytes, or non-classical monocytes? And in order to give an answer to this question, they studied different patient groups, which we see here in this diagram. They studied 68 healthy donors. They also included 74 reactive monocytosis, 79 non-CMML hematological conditions, and 86 CMML patients. The reason why they included these groups, the reactive monocytosis or non-CMML patients, is because they are the main groups that are having a mislead diagnosis, and they are mixing with CMML patients. So they wanted to check whether this subset that they don't know which one is increased can be helpful in the undoubtedly diagnosis of CMML patients. Both learning and validation cohorts were performed, and they used flow cytometry technique. They stained mononuclear cells to separate classical monocytes, intermediate monocytes, and non-classical monocytes. As I mentioned before, some studies still call these cells in their own way. In this case, the authors called classical monocytes MO1, intermediate monocytes MO2, and non-classical monocytes MO3. So as you can see, you can encounter different nomenclatures, but it should be now consistent throughout all literature as classical monocytes, intermediate, and non-classical. The gating strategy they used was based on the CD16, CD14 classification. Here they show the double negative plot, the double negative gate, which have dendritic cell contamination, most probably, because they are also DR positive and they are very similar to the monocytic compartment, but then with 14 and 16 they can be easily separated. And then they show here a healthy donor dot plot with the percentages that go like we showed before. Classical monocytes are 89% from all monocytes, intermediate monocytes 5.2, and non-classical monocytes 5.4. So this is in line with what we have seen before. In the results, they saw an abnormal repetition of monocyte subsets in CMML. Specifically, they saw that the monocytes that were increased in these patients, in CMML patients, were classical monocytes, both in the learning cohort and validation cohort. So we see here that this rise is significant when compared with reactive monocytosis group, non-CMML group, or the healthy donors group, both without age matching and age matching controls. And again, in the validation cohort, the results were the same, and you can see that classical monocytes can go really high in comparison with the other groups for CMML patients. So the authors further questioned themselves whether this marker could be helpful in the separation of these patients with higher sensibility and sensitivity. And they performed the ROC curve, here represented. They had a very nice area under the curve, and they found a cutoff value of 94%, meaning that the patients diagnosed with monocytosis in blood for more than 3 months, together with bone marrow dysplastic features and more than 94% classical monocytes in peripheral blood, can be diagnosed with CMML and can be distinguished from those conditions that have also monocytosis. So, in conclusion, for CMML, this condition is characterized by an increase in the fraction of classical monocytes among circulating monocytes. These cells, classical monocytes, the percentage of these cells could be used to improve CMML diagnosis. Specifically, the authors found a cutoff value of 94% of these cells, and this can be achieved with a rapid test using peripheral blood. It's minimally invasive, and using flow cytometry assay performed on blood to distinguish those patients with CMML from the patients with a borderline monocyte count within reactive monocytosis and other myeloid malignancies. So the second application I brought here today was within coronary artery disease field, and the authors, they performed the study in order to check if blood monocytes were important in the prediction of future coronary events. And it is considered among literature that circulating monocytes are responsible for the invasion and accumulation in endothelial artery walls. And moreover, these monocytes can subsequently differentiate into foam cells and contribute to the plaque formation. Also, some studies claim that human intermediate monocytes are supposed to play a key role in this process of the plaque formation, and they also contribute for the vulnerable plaque formation. So with these results in mind, these authors they have the aim to investigate whether human blood monocytes were or not related with the development of future coronary events. So here we see the distribution of the patients. All the groups of all the patients included in the study have no significant coronary artery stenosis, and they included 121 patients under medical therapy, but with no coronary event. 15 of the patients were also under medical therapy, but they do have coronary events, and then under 25 patients that underwent coronary vascularization. Again, the technique was the same, flow cytometry assay, but in this case they used total blood samples instead of mononuclear samples, and they also achieved the separation of classical monocytes, intermediate monocytes, and non-classical monocytes. A small difference here, they use side scatter and forward scatter to get the total monocytes, but then again they used the CD14 and CD16 to separate classical, intermediate, and non-classical. So what do these authors found? These authors found that at the level of the intermediate monocyte compartment, patients under medical therapy, but with no coronary event, they had less frequency of these cells when compared with both medical therapy coronary event positive group or coronary revascularization group, although these differences were not observed between the last two groups. So again, the authors thought that intermediate monocytes, the frequency of these cells in blood, could be useful to predict the coronary events. They then performed also a ROC curve, and in the ROC curve they found out that they could use a cutoff value of 19.2% of the frequency of intermediate monocytes in blood, meaning that patients that had lower levels of intermediate monocytes, they had a longer free coronary event period compared with patients that had higher levels of intermediate monocytes. When we say higher levels, as I said before, is more than 19.2% from total monocytes. And in conclusion, intermediate monocytes were lower in patients without coronary events. They established the cutoff on 19.2 to separate those with coronary event periods shorter or longer, these periods being shorter in patients that have high frequency of intermediate monocytes. So as I told you in the beginning of this talk, monitoring of tissue damage is also one application of monitoring blood monocytes. And here the study performed was after total hip arthroplasty. The authors used total peripheral blood fresh samples, and they made sure that patients in this study had elective surgery after great tissue damage. The results they obtained are depicted here. As you can see, they performed the analysis pre-op, 2 hours after surgery, 24 hours, 48 hours, 2 weeks, and 6 weeks after surgery, in order to study the kinetics of classical monocytes, intermediate monocytes, and non-classical monocytes. So just if you look quickly to this picture, you already see that all the compartments behave differently from each other, and that classical monocytes are very similar to the total monocyte compartment, because they are the main components of this compartment. So in the classical monocytes, the cells are decreasing rapidly after surgery at 2 hours, and then they increase to numbers greater than the pre-op numbers at 24 hours and 48 hours. Then 2 weeks after surgery, the cells return to the normal frequencies in blood, achieving the levels of pre-op results. Then the intermediate monocytes, also at 2 hours after surgery, they come down, but then they recover immediately 24 hours after surgery, maintaining their levels similar to those observed in the pre-op time point. And finally, non-classical monocytes again came down 2 hours after surgery, but then they maintained low until 48 hours after surgery, just recovering 2 weeks after surgery, maintaining these numbers at the 6 weeks time point. So these results again are in line with what we are discussing. The cells have different behaviors, total monocytes compartment is heterogeneous, and the kinetics is not the same in each condition that we have already seen here today. Then the blood monocyte reference values, it's also an important application in the field of the monocytic blood subsets. And why? Because with age, these cells are also changing. So these cells have to be studied by age group, because if our patients are in the group of, I don't know, for instance, from 40 to 60, the reference values for this group, it's not the same as if we study pediatric samples, for instance, or conditions. So here we show this is a study from last year, and we show that classical monocytes Here you see the different age groups that go from cord blood to individuals with more than 80 years old. And here we show that in the cord blood, we see high levels of classical monocytes, but we do not see the same pattern for intermediate or non-classical monocytes, which is in line with the theory that we talked earlier in this talk about classical monocytes being in blood. They come from bone marrow and established in blood, and then they can migrate to the tissues and then come again back to peripheral blood. So here we would be seeing this thing. So cord blood, high levels of classical monocytes, but then no intermediate monocytes or classical monocytes were observed. Then in the newborn age group, we already see that intermediate monocytes come up, but the non-classical monocytes still don't reach their peak, which they achieve in the next age group at less than 6 months individuals. So again, the kinetic, even if they are healthy donors, it's different with age group. So it's important to keep in mind our age group patients to compare with the proper reference values. So we came to the end of this talk. I wanted just to, before we go to the demo, I wanted to give you some take-home messages. Blood monocytes are an heterogeneous cell population, and they include, as we have just seen, different cells, different subsets. For this moment, they describe 3 different subsets based on CD14 and CD16. Classical monocytes, intermediate monocytes, non-classical monocytes, but it's also important to keep in mind the need for a good identification using the HLA-DR and CD300E. Under inflammatory conditions or tumoral conditions, the homeostasis is disrupted and our monocyte compartment will be altered. The frequencies will not be the same, and it depends on the condition we want to study. Can be classical monocytes or intermediate monocytes in the examples we have seen here today, but it's important to study the subsets separately and not as a whole compartment. And monitoring of these cells can be useful to different clinical applications like the ones that we have just seen here today. So now we will do the demo. We have a healthy donor monocyte subset tube, including the markers I told you, CD300E, HLA-DR, CD16 and CD14, and we will now do a practical session so that you can also participate, and if you have any question, then we can discuss it later.
This is the sample we are going to analyze now, healthy donor sample. We will use this profile, including our monocytes, but also the other leukocytes, and it's a good way to see our cells in this display. We have several dot plots, 2D dot plots. We have included CD45, which is a pan-leukocyte marker. We have also included CD14, CD300E or IRM2, CD16, and HLA-DR. With all these markers, the goal is to make combinations between them and to select properly our cells of interest. So we can begin with gating, with the gate on the monocytes. Monocytes will be included all together in this step. So we have HLA-DR and 300E. We can make a broad gate, making a good selection and ensuring we are including all monocytes here. And then after this first step, we can gate better in other dot plots. We have CD14 with CD300E. This gate is also useful to make a nice selection after the first step we have just performed. So here we would select all the monocytic cells, and again we have other dot plots, and we can make our selection even better if we exclude cells that are not within our gate. Here, sometimes you can have some contamination on our gate by neutrophils or NK cells, which are also CD16 positive. So it's also nice if we do this gate here. Then we saw also in the presentation the contamination that we can have in the double negative fraction of CD14, CD16 dot plot, and here we can gate our cells and exclude those events that are contaminating our monocytic compartment. When we feel that we are happy with our selection, we can then gate our cells, classify them within our tree, in this case monocytes, because we have all monocytes together. So the next step within monocytes, we know that we have to classify 3 different subsets, and we use 1416 for this purpose. Another tool that Infinicyt, this software, offers is the APS view. The APS view consists of a representation of all the events in the tube, taking into account all the markers. So in the dot plot we see 1416 alone, but in the APS we also include HLA-DR, 300E, 45, site scatter, Ford scatter. All parameters are represented and are being taken into account. So here we can see, obviously we have 2 different subsets. We don't know which one is classical monocytes or intermediate monocytes, but we do know that classical monocytes are the more abundant compartment within total monocytes. So I probably would say that these would be classical monocytes, and here we will have together intermediate and non-classical monocytes. So if we do our selection here, what is the advantage? With this, we can see our gate in all the other dot plots, and also we don't have to do cuts that then in an article it's not very nice to see these cuts. So here we will adjust our gate, and finally here we can also see that some cells are in the transition. These would be the intermediate monocytes. So we are happy with our gate. We can here also select the cells that have strong 14 and then the ones that are losing it, which will be intermediate and non-classical monocytes together. And also I didn't say anything in the presentation, but both intermediate and non-classical monocytes have more expression for CD45. So this is also a useful marker to make sure we are getting our cells correctly. So you can see here some events are here contaminating, but we can select and make a nicer gate. So with this, we can already separate these cells and classify them as intermediate monocytes, which will be further divided into non-classical and intermediate monocytes. Here they are together, but again, we can use the APS view and we can cut our population, and we can see with 14 and 16 that we have selected the intermediate monocyte compartment, but actually we want to classify the blue ones, which are the non-classical monocytes. So we can also, with this software, we have a tool and we can simply invert our gate selection. So automatically I will have now the cells I wanted to select, and here we have non-classical monocytes losing 14, 16 strong, 45 positive, and they we can also see here they have a little bit less expression on HLA-DR. So here we can now classify non-classical monocytes. And finally, the monocytes that we need now to classify are classical monocytes. You see that we have some events here that are outside the gate of intermediate and non-classical monocytes, These are probably debris, so we can exclude them. And finally, we can get our classical monocyte compartment. So you can see here, as we have seen in the examples on the presentation, we have classical monocytes, we have intermediate monocytes, and we have non-classical monocytes. So from now on, this compartment is finished. We can check our dot plots. We can see also nicely the different populations in the APS, and also the dots that you see here represent the mean, the median of the population. So this is also extra information that we can have from this software easily by just representing these dots and checking the median of our cell population. Now we are going to gate on the other leukocytes. So here we can also use the APS view. You see different populations represented, and we can check. We don't know what population are we gating, but we can gate and then check on the other dot plots what are we gating. So if we open the CD45, we see perfectly these are eosinophils that are located with high site scatter. They are autofluorescent cells, so in the other dot plots they may appear in the middle of the dot plot. It's not that they are positive, it's just that they are autofluorescent. So here we can gate our eosinophils, and you see the cuts are very clean because we gated on APS, and we will now classify these cells as eosinophils. Then we have another big cell subset, and probably this will be neutrophils. Exactly, we can now see again in the 45 with site scatter the location of neutrophils. They are CD16 positive, and we do have 16 because we need it for non-classical monocytes, so we can also use this marker for neutrophils. And we know they have no 14 or 300E. We can adjust again our gate, and finally we can classify them as neutrophils. We see that we have some events here. These will be probably doublets, these cells. We can see that on forest side height and area, and we can exclude these cells. And now we have more subsets. So we can use the APS view again. I will make it large for you to. So we have here some dots. We can gate on all, and then we can see what are we gating. So if we think about dendritic cells, these cells should have they should have HLA-DR. So maybe these are the cells we want. Remember, they would be on CD14, CD16 negative. They should be here. And in the 45, you see clearly. So if I start with 45 with no other gate, it's difficult to select these cells because they overlap with basophils, they overlap with lymphocytes. So if we start with the APS view, we make this gate first on a subset that separates from the others. Then I see they have HLA-DR. Okay, maybe they are our dendritic cells, or B, but the B cells should not locate here with the 45 dot plot. They should be on the lymphocyte area. So then we can nicely separate dendritic cells and put them here. You can see this plus. We can open our tree and we can get dendritic cells. Okay, then we can keep with this the identification of the remaining cells, the remaining leukocytes. We see here again a cell subset, a cluster separating from the other one. and we can just check on this cluster to see what is this. So there will be lymphocytes. We can adjust here, and then we have several lymphocytes. We have B cells, T cells, NK cells. So these cells, immediately we can see they have HLA-DR, but they do not express CD300E because this is a monocytic marker. So these are undoubtedly B cells. Another tool, the tree can be constructed from the beginning. So we can just say, please add a new population. Okay. And then he asks, the software asks, what is this population? We say, these are B cells. And I want B cells to be light blue. Okay, B cells. So immediately within lymphocytes, I create a new population called B cells. And I remove it. Here we can exclude these events with 300E and DR because they are not cells anymore. Maybe they are belonging to no, they are other cells. So these cells probably are contaminating cells from other gates. And now we have some events with HLA-DR still here. You see they come from another population because of the cut. So we can search for it. So with DR, maybe they are B cells and I cut them off. After, you see they belong to B cell compartment, and then we can keep doing our gating. So now we have some few dots here separated, and you can see they are not belonging to our main gate. Here we can see maybe they are classical monocytes. They fit within our classification of classical monocytes. So I just reassign these cells here. So we can now continue with the remaining cells. We already classified B cells, and now again in the APS we can classify NK cells for their expression of CD16. Here you can check the expression on CD16. Also, we need to ensure they are in the area of lymphocytes. They have no 300E. And again, you see here the 16 expression. So again, we create a new population. And we say we want NK cells to be green in this case, wherever you want. And after NK cells, we see here some CD16 events. The ones that are within lymphocytes should be from NK cells. You see here they belong on NK, so we just say to classify these events as NK cells, and the remaining are out of our gate and are debris. So, well, we can also clean on DR, and now we have two populations left on our analysis. In the 45, you can clearly see the difference between basophils and T cells. T cells should be here, and this we can classify again, making a new population. These would be T cells, and they can be pink, for instance, and they are classified. And the remaining events, here we have some contamination from previous gate, from T cells, and the left events would be basophils. also within basophils. You see here these cells are coming from aggregate. These are debris. We can see here it's dead cells. We can remove it. And now we can plot all our nucleated cells and see how nice they are distributed in the 45. We have also the value for the median fluorescence intensity for 45 in this dot plot for each population, but we can also have these values, for instance, in the CD300E for classical monocytes, for intermediate monocytes, and for non-classical monocytes, but also as a negative reference we can use NK cells or B cells or T lymphocytes, whatever we need to. Now, after finishing our analysis, we can say to the software we need a report. We need to check the numbers and see if they are in our range, within our range, our normal values, or if this, in case we were analyzing a patient, how far are they from our reference values. So this is easy if you click here in the open report, and then this is a report I already customized, but this is user friendly and you can do it the way you prefer. Here we have the CD45 dot plot showing all the leukocytes, and we have also the CD14, CD16 dot plot showing classical monocytes, intermediate monocytes, and non-classical monocytes. Furthermore, we have also our results from our sample, which are showing the percentage of cells from the total monocytes. In this case, in our sample, we have 90% classical monocytes, 4.7% intermediate monocytes, and 5.3% non-classical monocytes. We can also add a table with our reference values. In this case, for the sample we are analyzing, in the age we want to study. In this case, this sample was within the 40 to 60 years old, and the range, the values for this age are for classical monocytes 90%, intermediate monocytes 2%, and non-classical monocytes 7%. So we can also add the range, the minimum and the maximum values, and check whether our sample results fit our reference values or if we are leading with a patient sample and these values are altered. So this it's all that I wanted to show to you today. You can then save your analysis to check it later, and this is a very nice way for analyzing samples, and the software actually is very easy to use from a researcher point of view. Thank you very much for your attention, for being with us for the last 50 minutes now. We are now opening our questions, our session. You can ask, you can write your questions, and I will try to answer the maximum questions I can. You can also use my email to ask if you have any question from this session, and I hope you learned a lot today and you enjoy our talk.